Thank you, sir. So I thank the organizing committee for giving the opportunity. And as sir has said, that it's been accepted in IDF. It's a multi-centric data on oral SEMA. Now, we are all aware of oral SEMA. That's the first oral GLP-1 that has been there. And the prescribing information, you start with 3, after a month you go down to 7, after a month you go down to 14. How much of that is practical, how much of that is realistic is something which we're gonna look at and all of us decide. So what we looked at multicentric data from quite a few centers in India, cutting across geographical boundaries, to look at the efficiency and safety, mainly efficiency, because safety you cannot see in 1 and 3 months, in 1 month and 3 months, and see what we were. We kind of excluded all type 1 diabetic patients that were there, and adult patients is what we actually looked at the data, whoever initiated on oral semaglutide. Now, sorry, I skipped there. We looked at retrospective data from the author's clinic, analyzing the effect, and the mean duration was 3 months from baseline. They received treatment as standard of care, because real life standard of care is very different to what we encounter in research or experimental studies where things are very different. In real life, people stop their medication for a few days, something else happens, a lot of things come in, and that is what we live in. That is what we are, and it's important to see how that has an effect on our body. So we looked at the weight, the blood pressure, fasting PP sugar, AST, ALT, and urine ACR at baseline and 3 months. Now, this is very important. Chawla sir is a part of our group, so it's very nice that he's chairing the session. And we looked at across India. We had Dr. Pankaj Aneja from Delhi, Dr. Rajiv Chawla, Dr. Makkar sir, Dr. Arun Pandey from Lucknow, Dr. Bansi Sabu, Dr. Jyoti Dev, Dr. S.K. Singh from Patna, Dr. Debashish Basu, Dr. Devmalya Sanyal, Dr. Anirban Majumdar, Dr. Soumyabrata Roy Chaudhary from Calcutta, Dr. Sunil Kota from Berhampur, Dr. Sambit Das from Odisha, and Dr. Subhas Kumar. So we kind of tried, because as sir was saying in the previous presentation, if you have it from one center, maybe there's a geographical bias. So let's see what happens if we're cutting across a bit of geographical lines to see what's happening. Now, in the prescribing information says we start with 3 milligrams and then you upgrade after a month. But we found, based on clinical practice, clinicians' practice, only 76% received a prescription only for 3 milligrams. Rest 24% started on 7 milligrams. Now, could be a reasons that they moved from another GLP-1, or they found that 3 milligram would not do the desired effect for practical benefits. And even though they were started, the titration was much faster. So even titration from 3 to 7 after 30 days was recommended, 38% up titrated dose after 10 days, and 26% after 20 days. So maybe left them for one, because it comes in a box of 10. So left them either one box and moved up to 7, or 2 boxes and move up to 7 that were there. This were the initial results in 4 weeks. So we looked at the mean age of patients was 53 years, and 179 patients were there. It started accumulating after that. So we looked at glycemic parameters and body weight BMI, and we'll look into that individually. If you look at glycemic parameters, it improved, with the fasting improved from 169 to 114. There was a drop, and PP from 229 to 147. There was a decrease in body weight around 2 kilograms in the first month, and the BMI decreased marginally as well. The blood pressure decreased very transiently from 138 to 132 and 83 to 80. This was now the follow-up at 3 months, which we looked at. The mean age was around 50 years. More people were there now, 224 patients. And we looked at glycemic and other anthropometric parameters, which I shall compare to what actually the data from the Pioneer showed, so that we know what it showed and what we have, and is there a discrepancy, and what are the reasons that could be for the discrepancy. Now, oral SEMA has shown benefits of around 1.5% in all their trials as an average on 26 weeks, which is roughly 6 months. So we don't have 6 months data, we have 3 months data. This is what we have, and this is what we'll see. So if you look at 3 months, there was a drop of fasting from 179 to 116, PP from 236 to 141, and close to around 0.8% drop of HbA1c in 3 months' time. Maybe we are following our data. More people have joined in already. So we'll have 6 months data very soon, and we'll see what that shows. Now, in terms of weight loss, the oral SEMA across the trials have seen an average around 5 kilograms of weight loss. across the pioneer trials. In our cohort, we had around 9.5 kilogram weight loss over 3 months and decrease in BMI that is there. If you look at blood pressure, there was slight improvement in systolic blood pressure and slight improvement in diastolic blood pressure. If you divide this cohort into baseline HbA1cs that were there, as we know, if you have a higher HbA1c, the chances are you will drop more. So that's what we found. Patients who had higher HbA1c got more benefits than patients who were, less or tighter HbA1c that were there in terms of the drop of the HbA1c. Now, if you look at the subgroup analysis of Pioneer trial, it shows that it reduces HbA1c and body weight in patients with T2DN, regardless of background glucose lowering medication. So what we are going to concentrate now is on SGLT2. So even if they're on SGLT2, it reduces HbA1c, and there is no difference with and without that is there. So let's look at what we did. We divided our cohort of 3 months with SGLT2 and without SGLT2 and looked at whether there was any difference. And we found even that there was no baseline difference in the characteristics of the group, and the improved glycemic profile was found in both the groups, with SGLT2 and without SGLT2, with no significant p-value that was there. So saying that it didn't really matter whether the patient had another combination, specifically looking at the glycemic parameter. However, there was a better benefit that we found in patients who, in their blood pressure, who had a combination with SGLT2, and the p-value was a little significant in systolic and diastolic blood pressure. There was the body weight and body mass index, there was no significant difference between the two. If you look at urine ACR, urine ACR is very important to look at because in the Pioneer trials, they never looked at urine ACR with and without SGLT2. And we found that there is a benefit if you combine that with SGLT2, the urine ACR reduction is better. In patients without SGLT2, there was a drop from 84 to 60, and patients with SGLT2, 104 to 68. There was an improvement in AST. There was no difference in ALT in our information that was there. So overall, that we found that though this is preliminary data, I think it's a first attempt to have a multicentric data across boundaries. And we are going to look at 6 months and further down the line at 1 year. We're coming with an app also to store data so that it's easier to store the data and easier to see what's going on with the population. The other thing was a distinct thing that I noticed in my patients is that patients often complain of a sour taste when they put the oral semaglutide in their mouth. That could be because of the molecule or because of the snack. So what I advise my patients is that I ask them to gulp a little bit of water because there is more natural lubrication. So the contact time of the tablet to the tongue is less, and so the foul taste is kind of obliterated in those patients. With that, I end my talk. Happy to answer any questions.